Troy, and on this blustery day, which is something we're very used to in Cumbria, as you probably will all imagine. We do weather, but not as much as they do it in Scotland. So that's probably the definition, so that defines us. I work for a local authority, Carlisle City Council. I manage a home improvement agency. I have a role also across the whole of Cumbria in terms of the county. I coordinate disabled facilities grants for the districts, either doing or not doing, as my colleagues at the back there who are here also will either agree or disagree with. And I also support the Health and Wellbeing Board. We have 3 district councillors on our Health and Wellbeing Board in Cumbria, and I support those members. And as you probably are all aware or not aware, the ITFs the local plans all have to be signed off by the Health and Wellbeing Boards locally. So what I'm going to do is I will set my presentation up because in a way so that you had all had a good grounding from Lorraine and from Phil, because I know them both and I've seen their presentation, or I know their presentations from other things, and they would have given you a background. I'm not going to go into what the ITF is and what it's about. I'm going to just directly focus on the experience of housing, the experience that we have in Cumbria, which may be different where you are, and to give you some pointers as to things I've heard from other people about how the ITF local plan, which is the first task, is going. Now, I'll give you some background on Cumbria. This is a slide I seem to use everywhere I go. It's basically giving you a notion of what our problems are in comparison to the rest of the country. This is just a very simple slide showing you the percentage of the population aged 65 and over. And it gives a projection. This is in fact from the 2001 ONS. There'll be another one after the 2011. But as you can see, the top pink figure line is Cumbria. The blue one is England. England's population is projected to rise, this over 65, up to about 22%. We're projected to rise up near to 30. And it's probably higher than that from the latest population census. So why is that? Well, we're a rural area. We also we're a coastal area. And if any of you saw years ago the Audit Commission's report on ageing population, it predicted that coastal and rural areas would have higher rises in ageing population than everywhere else. And there are good reasons for that. We have people who retire to our area because it's really lovely and beautiful, and at the age of in their 50s or 60s or early 60s, we have couples retiring to walk the fells and to have lovely outdoor lives and to live in that wonderful cottage somewhere in the middle of nowhere, etc., so on and so forth. They then grow older into their 80s. One of them develops early onset dementia, perhaps maybe has some osteoporotic conditions, or perhaps maybe has a fall, gets looked after by the other partner. The other partner then dies, and then they're stuck up a track on a snowy winter's day with some of them not being able to drive. You can get the scenario, social care needing to be involved, etc., etc., etc. So the scenario that people dream of at the beginning in coming into Cumbria doesn't sometimes work out exactly as they had hoped. And that, of course, means then we end up with an ageing population in a lot of our rural areas where we might have, for instance, in some of our villages, 70% of the population who are over 65. Huge difficulties for us in terms of housing because, of course, all the housing has been brought up by people who can afford to spend lots of money on cottages and things like that because it's the rural idyll, and therefore the younger people who were born in the village can't find themselves an affordable house. And if we say to them, can we build some affordable housing next to your lovely view or in front of it, of course they turn around and say, you are not doing that because, this is my thing I've promised myself for the whole of my life. I've worked for it forever. There's no way you're going to plonk a social house in front of my view. So then we have nowhere for our young people to live. They all move out of the county, and thus our population starts going on this spiral. So that's what's happening in Cumbria, and there's just an illustration of it. And of course, as people grow older, they have all sorts of more difficulties. Now, this is the wonderful thing to say about all this. I talked in Cumbria with Professor Goodwin, who's the research guy with Age UK recently. And he said that there's someone on the planet at the moment who is going to live to 170. That's what the prediction is. Probably a woman or a young baby girl, and living in Japan. So that's the prediction. In Cheshire, there are 6 women at the moment who live over 100 who are in their 60s. There are people in this room, some of you, who can easily look to living to 100. because of the changes in medical practice, in public health, in all the wider determinants, all the things that we deal with on our daily basis. That is a prediction. You may have seen, today the Chancellor will be getting up and announcing an increase in the pension age for those of you in their 40s going up to 69. That's because we're all living longer. Now, the thing is, as we live older, at the moment, and medical may change, I don't know, lifestyle, whatever, is we end up getting more conditions. So living longer doesn't mean necessarily living healthy. And as you get older, this is the current sort of situation, you run into your 85s and you might have as many as 8 conditions. 8 conditions. Some of you in the room have got some at the moment. I've got one. I've got a dicky hip, which I sort of got when I'm in my 30s, very early onset, sort of stuff like that. But there are other things, and we get stuff as we go along. Some of us start life with things already. And so life is not going to be, for everybody, by the time they get into their old age, a healthy life, unless we have some really dramatic changes, either in the way that we all live, in our health, in our public health, etc., etc. And of course, there are other factors, as you all know, in terms of whether people have healthy lives. There's a strong correlation, for instance, between poor housing and ill health. And as many of you have seen, the stock condition in England is very poor. It's sort of almost becoming internationally known as very poor. One of the things that you can remember from a couple of weeks ago or a week or so ago, the 31,000 people who have the excess winter death figures that came out. And the northwest, where I'm from, I haven't got the Cumbria figures yet because we're trying to verify them. We had the highest rise in excess winter deaths from the previous winter. Falls on stairs, after warmth, second most common hazard. Some of you may know this because we're trying to tell everybody is social isolation is more harmful than you being a smoker. I was lucky enough, and that's the reason why I'm on first, I stayed somewhere overnight and there was a party going on in the hotel I was in of people, probably 16, 17-year-olds. So you can imagine what it was like. The whole place was full of people, dare I say, I don't know, but anyway, I'm probably getting too old, but it was bizarre. But outside on the front steps of the hotel, to get in after I'd been out to get something to eat, I came back and there was literally a huddle of about 10 people in a sort of circle stopping you getting in, all of them young people smoking. As is my wont, I stopped on the steps. Right, can I persuade any of you to stop smoking? And I started telling them all the stats. I told them why they should. You can imagine what they said to me. One of them said to me, yeah, but if I stop, won't my lungs recover? I said, yes, but, and I didn't even get as far as telling them about what the effects on their faces would be as they smoke, etc., which, because, it makes you age quicker. I'm trying to think of all the arguments, but anyway, never mind. So, getting back to social isolation. The great thing about them is they had friends and they were sitting in a group. Social isolation is not the same as loneliness. Don't equate the two. Loneliness can be experienced as in a group. People feel loneliness for all sorts of reasons, but social isolation is literally what it means. It's on the tin. It's being on your own, not seeing people. And many of you will have come across in your work people who don't see anybody once a week, twice a week, very little. And it's actually not very good for your health. So that's one of the effects of an ageing population in a rural community. That's very, very serious. We've got income pressures on the old. Again, things like annuity rates are low. Pensions are not delivering what they used to be. And of course, we've got benefit changes, not so much affecting the old, but affecting lots of people in the population. And as I mentioned, in an area like my own, we have people who live quite a long way away from their relatives. If your children have moved away, and I'm very common, some of you may even be in this world, where you have an older relative who's about 3 or 4 hours away from you, and you get that phone call at 10 o'clock at night when they've had a fall or something's gone wrong. What do you do? And there are lots and lots of situations like that arising. And as I've mentioned before, this issue about resilience is really key in this process, when a partner or a carer dies especially. So, if I just give you an overview of the current situation for us, 45% of our over 85s use social care at the moment. It's not a huge amount of people in terms of the population. The population's 500,000. We have about 14,500, 15,000 people who have a social care package, including young people with disabilities and learning disabilities, all that mix. So it's not all older people. The population of over 85s, given the scenario, the graph I showed you at the beginning, is set to double and change. And yippee, men are living longer. Don't know why, but whatever. There's also a higher divorce rate when in the over 65. So going back to the slide that of the sperm and the egg and all that sort of malarkey, there's also another side at the end of it. Women may be becoming less tolerant of men in their 60s who won't do anything to help. Is that probably close. Is that something like that? Yeah. So it's finally the I'm not putting up with you any longer, or I'm not going to look after you in your old age, you know, etc. You can look after yourself. So men are now sort of baking and sort of finding out how to be, you know, whatever sort of thing. I don't know, whatever. Anyway, so I don't know what will win that one anyway. I think there's another thing that's happening also, and it's to do with the pension things, and I can digress because nobody's here, so I can talk on. There's another thing that's happening is some of our over 65s are losing it. This is CAB locally to us, over in the west, dare I say it, near Whitehaven. She was saying that she's getting evidence that some people are just simply giving up because they don't have the money. Their lifestyles are changing, but they're also their relationships are beginning to go, and they're beginning to feel like, actually, what's the point? Because everything doesn't look like it's going to be. If you've got another possibly 20 years of your life ahead of you, you know, I mean, I'm at a point, I'm in my late 50s, so I'm sort of thinking about, well, what's the next stages for my life? If I'm going to live like my grandmother to 92, I have another, 35, 40 years on the planet. So it could be even longer. I don't know, because I'm reasonably healthy. I don't smoke, don't drink, I exercise, etc., etc., etc. But you know, whatever. The point is how do I frame my life from that point? I'll retire like I'm a local authority worker. I'll probably retire 66, 65, whatever. It might get changed, but whatever. Chuck me out before then, probably. The point is I'm having to think of my life in totally different terms, and I suggest that that's also something that reframing is affecting the way people feel, because the promises and all the expectations that people have are changing. We've got a situation in our hospitals in A&E where we've experienced winter demand levels in April, May of this year, which were equivalent to our winter levels, which is very unusual. So there are certain things that are happening in the system which we didn't predict. There was a week in October. I live in this, or work in this, I say I live in it, it's probably near this point. I work in this building that overlooks a big roundabout in Carlisle, Hardwick Circus it's called. And it's the main route in from the M6, from the Eden Valley and out in the rural areas to our hospital, Carlisle Infirmary, up the road. And when that roundabout, when I look out and it's got ambulances going round it all the time, I know we've got a busy week. Well, it sounds counterintuitive, but it's true. If I notice lots of ambulances coming up the north on the M6, if I'm travelling down to Penrith, again, I know things like that are happening. So these sort of moments you can predict, but they have a huge effect on the way the whole health system works. We've got social care funding, which all of you will be aware of, it has a shortfall, and health spending is flatlining. So I'm trying to contextualise where ITF sort of fits. The evidence is also emerging nationally. This is what sort of ADAS are saying, social care directors, is that if you invest in prevention, and those people that did about 2 or 3 years ago, that you're feeling less pain now. So in other words, it pays to invest in prevention. It will help. So what's happening in Cumbria? Well, we are a two-tier area, which means we have a district council, a county council. And the county council is the upper tier authority, as some of you who live in those sorts of places, who do social care. We're the housing authority. We do the DFGs, all that sort of stuff. We have asset-based community development. Does anyone know what asset-based community development is? Gosh, blind. Oh dear. Right, okay. It's a thing that there's a guy called Professor John McKnight, who was one of Obama's mentors. So he basically has developed, in the 60s, he was a great community development worker in Chicago. And we had a director of public health who's now the head of the Faculty of Public Health, Professor John Ashton, who was very into asset-based community development. And he got Professor John McKnight to come over and give seminars and talk to us all. And basically what it's about not looking at your communities as a deficit, but looking at them as resources. So if your communities want to do something in their communities, you don't go to them assessing them around their needs, so not a joint strategic needs assessment that says, well, these are all your problems. You look at all the qualities and the things that they have and what they can give. And you ask communities about what they feel they need to develop and grow to make the places where they live and how they live better. And you don't give them any resources. That's the real nub of this. You let them grow those resources from what they have. So it's a very American solution, isn't it, in one respects, if you can think about it, to the welfare, world, state, whatever. It's not something where you meet need with funding, but you meet it from what is available on the ground. And in Cumbria, that's really important for us because we don't have any extra money. And I think that will become more and more of a process as we go on. Now, it's a shame Lorraine's not here because, and I will repeat this when she's here, the NHS national funding settlement currently at the moment, this is Department of Health have said to the NHS England, we want you to create, or we want you to impose a new, I say impose, should be wrong, we want you to apply, because Lorraine's not here, I can say impose, a formula to change the way health spending is divvied up throughout the country. And what's going to happen is that the amount of money that the NHS has per head is going to change depending on where you live in the country. Now, what it means for the North is going to lose, or Cumbria possibly, about 10% of their health funding. And this has huge implications for the implementation of the ITF. Speaking to the chair of our CCG, our Clinical Commissioning Group, he reckons that it will cause the health people to fragment back into their silos. So we've had some very, very good discussions at the Health and Wellbeing Board and with our CCG about the notion of upstream spending into communities, spending on prevention, spending on helping people remain independent at home. We have a closer to home policy in Cumbria. And the GPs have been very supportive of this and supportive of the whole process. But if we lose an enormous amount of health funding because of the changes to that formula, dare I say it, places like Surrey, Berkshire, and in the south, they will get more funding. Why? 2015 election? No, couldn't be. Politicians are not like that, are they? They don't make decisions based on whether or not it's advantageous to them in the poll. No, they don't. No, sorry, I shouldn't have said that because that's on film now, and that could be awful. My MPs will say that, though, and they do say that. So we have a situation where the ITF, whilst it may be a wonderful thing, integration, I'm a great fan of it, this change in the funding settlement may actually change people's attitudes because they're having to deal, there's no new money, but if we get actually a cut because of a funding settlement change, it will change the way that we can deal with the ITF. The other thing about it is there's a very short deadline. The deadline we're working to in Cumbria is the 21st of January. And another scenario about Cumbria that we have hospitals in special measures. Go back through the timeline of history and news. All of us work on week cycles, or is it 3-day cycles, or whatever it might be. Everyone may have forgotten the Keogh report, which was looking at mortality rates in hospitals. It was a result of the mid-staff's hospital stuff. And basically, we've got our North Cumbria Universities Trust and is in special measures. That does 2 of our large hospitals in Cumbria, one in the west and one in Carlisle. And what that means is their mortality rates were higher than would be normally expected given national conditions. The leader of my council has a lovely story, just to give you an idea about the way things are. He went down to visit HMS Victory in Portsmouth, he's got a relative down there, and they went round HMS Victory and they looked round the boat, etc. The chief petty officer, you can imagine the thing, beard, hat, all that stuff, retired, booming voice, took them downstairs into the place where they did all the amputations. And in the Battle of Trafalgar, there were 11 people who had an amputation due to an injury caused by all the stuff that was flying around, the cannonballs and things. One of them died, and that was from injuries not sustained as a result of the amputation. 10 of them survived. So in other words, they did the amputations in a room with saws, with all the stuff that you can possibly imagine, no anaesthetic, it was probably alcohol, bit of wood in the mouth, that sort of stuff. But 10 of them survived. He made the statement after he'd said that if we'd sent them to Portsmouth General Hospital, 4 of them would have died. Now, if you speak to people who talk about our health service, there is squillions and millions and billions and whatever of pounds going into a system which is less reliable than HMS Victory in the Battle of Trafalgar. Now, that's a bit of an exaggeration, but there are many people, especially in public health, who think that the whole system is in real need of some change, and it is. And so we have a situation where the sector is also, I think, like fiefdoms. You have the acute sector on one side, you have the CCGs on the other side, you have public health on another side, you have Department of Health, somewhere else. You have, and ministers, of course, wanting to make sure that everybody feels the NHS is safe with us. Notice that phrase, that was the one that the government used. Our county council needs to save 80 million in the next 3 years as well. That's another saving on top of a previous saving that they have to make. And there are certain areas of their budgets which they've ring-fenced. we have an Ofsted report on our children's services which said they were poor and failing, because we had 5 serious case reviews, which obviously deaths were involved. So they're going to not touch children's services. A lot of the savings are going to have to be made around social care. And that is within, go back to first slide, a rapidly ageing older population. And with those figures about over 85 set to double, 45% of them needing social care, you can see it doesn't add up. Common sense tells you it doesn't add up. So the solution is integration. So integrating health and social care. Why are we doing it? Well, I'm sure that Phil and Lorraine will tell us about why it's happening as we go through. But one of the principal areas is, to, again, as Roy's just said, is to avoid duplication and to try and get some efficiencies through the system because of this bringing things together. So what's happening? Well, this is some stuff that from the Health and Wellbeing Board meeting that we had a few weeks ago, and a guy called Liam, who's chair of the Health and Wellbeing Board in Oldham, he has been talking to people, and he says there are basically 4 models coming out of the ITF approach in different areas, because everybody's doing it different. Localism, which Roy mentioned, being one of the key things in it. Some people are approaching it as a Bandaid solution, which means what they're doing is they're coordinating their existing networks, doing not much changes, but putting sort of connections, bits of sticking plaster over where things are not working. There's some people who are doing a sort of carve-out solution where they're re-engineering the whole thing, changing it completely. And then the other 2 things that are interesting, which is about the power struggles within the health service, which I think is really quite important, is that there are some people who are looking at it as an integration model which is directed from the hospital, the acute sector, and then there are others who are integrating it from the GPs. Then the models are really that you're getting from the hospital a sort of geriatrician-led process, and then from the GPs it's more like primary healthcare communities. You're having this cluster of people around a GP practice, and everybody's in some way either in the building or involved with that building, and everything's coordinated in the community. There are examples of the geriatrician-led process, which would be possibly things like virtual wards, which are directed from the hospital out in the community. So you can see that it's an idea. The idea is one idea is that it comes out from the hospital, the other idea that it's in the community, and that's where all of the integration takes place. And then you're basically saving money by not having so many people admitted into hospital, which comes back to really to the sort of parameters or the performance measures, which I'll get on to at the end. From what I'm hearing, some people have already completed their plan, which is extraordinary, because I think there's still some guidance about how that should happen, and remember, all of these plans have to be signed off by ministers. That's the way it's going to work. Health and Wellbeing boards are also going to have to sign this off. I think some people are waiting for the planning guidance to arrive, or some more guidance about how they do it. There is a template that was made available in October, and some guidance and letters and bits of paper about telling you how to do it. Some people, I think, have health and wellbeing boards which, quite honestly, haven't, because health and wellbeing boards, some of them are in very, very good state. They're well organised, they know what they're doing, they have a very good plan ahead of what work might be. Others, because if you April was when they first became statutory bodies, are not ready. Some of the members who are on the board haven't had a lot of experience of the sort of way that the health service works, the way that social care works. Some of them come from totally different backgrounds. You know, we've got the police commissioner on ours, we've got some of my district council members have a bit of knowledge, but not the sort of detailed knowledge that you'd need to understand if you were going to actually take an integration plan that involved health and social care and all of the stuff that involves, and be able to look at it and make a very good objective view as to whether this is a plan that will work for our area. There are those of us outside of the health and social care process, and many of us in housing are. We're not in the loop. I think that many of us have not been involved in the development of a local plan. And certainly, I think when you live in an area with a rapidly older population and possibly with a cut faced in your health budget, you are going to find it very, very difficult to do any large-scale re-engineering. And I think the ambition for the ITF, given that there's no new money, Given the constraints, we might even have less money in Cumbria. In the north, we might have less money. There's going to be a lot of pressures on that ITF because it's going to have to deliver savings rather than deliver any of this movement of funds upstream into housing and into the sort of wider determinants of health to stop the rapidly ageing population swamping the health service, which is, of course, what some of the aim is. So although I'm a great fan of integration, it's problematic for all the reasons I've said. We've discussed it at the Health and Wellbeing Board. We're very much led by social care, I think, and that's because, as you probably know, for many of you in upper tier authorities, it's where the health and wellbeing boards are. I personally think that was a wrong decision. I think public health also should not have been placed in the upper tier. Most of the things that affect public health sit within district councils. They don't sit within public health. I remember I sat down at a meeting where we were looking at the obesity challenge, and there were district colleagues and county colleagues sat round the table, and the question was asked, right, what can everybody do to try and reduce obesity in our communities, etc. District councils, hands up, leisure, all this stuff, ideas flying off the whatever. County colleagues put a hand up, or we can give some advice and information. So you get where the process is. There's, again, totally misunderstanding how two-tier authorities operate, and this is, unfortunately, I think some of this has a reflection on it. We've set a meeting up. We are involved. I represent the districts in our area, and Healthwatch and the third sector are involved. I don't know what that will mean. We have a working group. There's apparently a board which is meeting on Monday. Now, I'm not attending the board. Apparently, it's just going to be health and social care that are going to attend that board because, of course, if you've got a social care system that's trying to save 80 million and you've got a health sector that's thinking it's going to get a cut, they don't want anyone involved, just themselves, because they want to sort of, I don't know, work it between them, inverted commas. We might end up with a draft, very early stages at the moment. We might get some housing stuff in it, but I think it's going to very much be housing on the periphery. I don't think there'll be any investment in that document for housing. I think it's a total wasted opportunity. I think we will end up with a health and wellbeing board to sign it off, a special health and wellbeing board to sign it off, but that'll be right up against the deadline, right up against the 21st of January. But there are opportunities if people could only open their sort of consciousnesses to it rather than just worrying about money, worrying about the cuts in the health budgets, worrying about whether they can keep their fiefdoms, their little worlds the same as it always has been. Highest paid public servant in Cumbria is a doctor, just to give you sort of notions. Little businesses, some of them have two hats, partnership trust hats, some of them are involved in all sorts of things. They are, some of them are a real piece of work, to be honest. The hospital at home is a thing we've just introduced in Carlisle, part of our Mrs. Carlisle project, where we're treating 30 patients, and it's a trial process in their own homes. We've moved a team of people out of the hospital, and they're supporting them there. They absolutely love it. The patients love it. The staff feel it's a real change in the way they're providing care. They're absolutely enjoying it. We're going to do more of that. Again, it's a bit like I was describing before, that geriatrician-led process. Delayed discharge. We have a home improvement agency, I said, in Carlisle. We've now got a housing caseworker funded by the CCG who's actually intervening in housing problems where somebody can't get out of hospital. Example B, she's got somebody who owns her own home. She's used choice-based letting to find them another property, and we've just bid on it yesterday. Hopefully, she's able to be discharged. Let's make that point. She shouldn't be in hospital, but she's stuck there. We found somewhere for her, a bungalow, which we've bid for. Hopefully, we'll get that very, very quickly, and she'll be moved out of hospital into a new property, and then we'll help her dispose of her other property, and we'll do stuff like that. So there's opportunities, and some of you in home improvement agencies know that sort of work and are already doing it. So there's lots of work also that housing can do to prevent emergency emissions by upstream housing interventions. Things like affordable warmth measures, for instance, making homes warm and safe for people. We already do that. Some of the eco announcements which were made and will be made today and at the beginning of the week are totally and utterly ridiculous when you are looking at trying to put measures into people's homes to make them warm and safe. We've gone back to cavity wall insulation and lofts. And it's like, in Cumbria, we've got solid walls houses. They're stone built, But we've already done cavity walls. We've already done lofts to death, you know. Going back to the sperm and egg process analogy, the only lofts that are going to get done are virgin lofts. I don't know what that really means, but that's the term we're using. One that's not met a sperm, but I don't know. But how does a sperm meet a loft? I don't know. But anyway, but we're sort of in that world where what's going to help us, what's going to make a difference, what's actually going to do things. We've had that eco thing just pulled away. And the energy companies are probably on champagne till Christmas and beyond, I would imagine, because they've taken all that money off each of us, £54 a year out of our bills already. Some of them, like British Gas, haven't delivered, so they've had the money but they haven't spent it, and now they're being told they don't have to spend it, don't have to meet a target, don't have to, etc., etc. So please, you know, go on. I won't go on about that one. We can help reduce also admissions to nursing and care homes, which is again another target in the ITF. We do it already. Keeping people safe at home. So the housing sector has a huge role to play in getting these performance measures across. We've just started looking at respite flats, places where people who are inside step-up, step-down units or inside hospital can go whilst we make their home safe. So we're looking at that. I've mentioned affordable warmth. And we're also doing things like to make the housing stock better, managed repair services. We do that using people's own funding to help them do the house up, maintain it, that sort of thing. For us, I think that's a huge opportunity where we are. And of course, we've got handy person services. But the question is always, will the local plan or the ITF actually fund any of these services? Now, I think from what I've said, if we're going to, in my area, get a 10% cut in health funding, if health and social care are trying to, or social care are trying to find, the county council trying to find 80 million over 3 years, you can see that there ain't going to be, and it's no new money, it's going to be extraordinarily difficult. We've got an interim director of public health in our area, and she sat at the Health and Wellbeing Board. She probably won't mind me saying this. She said for 20 years she's been sitting in meetings talking about when health, the acute sector, is going to take money from there and pop it upstream into public health, into housing, into warmth, into safe homes, to basically stem the demand. And they've been talking about it for years. This is another thing where people are saying, and you'll hear it from ministers all the time, this is the opportunity to move that money from the acute sector, out of the acute sector, upstream into housing, and start doing that stuff which for 20 years public health and housing professionals have been saying we need to do. This is the time to do it. But will it happen? Any questions? Well, we'll do questions at the end, shall we? Well, that'll be great. As you can see, I'm sort of really positive about it. But I think also I'm realistic, I think. Thank you. Thank you.